1. Background. The oral microbiome is increasingly recognized as an important part of overall health. Rather than viewing oral bacteria simply as harmful organisms to be eliminated, current thinking suggests that the mouth contains a complex microbial ecosystem. Some bacteria may contribute to disease, while others appear to support oral and systemic health. In this context, oral care products should ideally support microbial balance while still protecting against tooth decay, gum disease, enamel erosion and bad breath. 2. Summary of the introduction of fluoride and related concerns. Fluoride was introduced into modern public health dentistry during the mid-20th century, following observations that some communities with naturally fluoridated water appeared to have lower levels of tooth decay. The first major community water fluoridation scheme began in Grand Rapids, Michigan, in 1945, and this became a reference point for later fluoridation programs in other countries. The UK followed with fluoridation trials during the 1950s, although fluoridation has never been universal across the country. Current UK parliamentary material notes that fluoride is added to water supplied to approximately 10% of the population in England through fluoridation scheme. Fluoride exposure also increased through consumer dental products. Fluoridated toothpaste became commercially significant from the mid-1950s. Crest toothpaste, introduced in 1955, was one of the first major fluoride toothpastes and helped establish fluoride as a routine part of dental care. The original public health case for fluoride was based on its ability to reduce dental decay. Fluoride supports remineralization of tooth enamel, makes enamel more resistant to acid attack, and can reduce the activity of acid-producing bacteria. These effects explain why fluoride has been widely adopted in dentistry. However, the introduction of fluoride also raises legitimate questions. Fluoride is biologically active, and modern exposure is not limited to one source. People may now encounter fluoride through drinking water, toothpaste, mouthwash, professional dental treatments, supplements, tea, some foods and, in infants, formula made with fluoridated water. For this reason, the question is not simply whether fluoride can protect teeth, but whether total lifetime exposure is always appropriate for every individual. Concerns have increased in recent years around the possibility of unintended effects, especially at higher exposure level. The U.S. National Toxicology Program concluded that higher fluoride exposure is associated with lower IQ in children, although its findings were strongest for exposures above 1.5 mg/L and less certain for lower exposure. There are also wider theoretical concerns about whether repeated fluoride exposure could affect the oral microbiome. Fluoride is not simply a broad antiseptic, and its main dental benefit is enamel protection, but it can influence acid-producing bacteria and biofilm behavior. As the oral microbiome contains both harmful and beneficial organisms, it is reasonable to ask whether long-term exposure could affect microbial balance in some individuals. The ethical concern is slightly different from the scientific one. Toothpaste and mouthwash are personal choices and are mainly topical. Water fluoridation is a population-level exposure that is ingested and not individually selected. This distinction matters, especially now that fluoride toothpaste and non-fluoride remineralizing alternatives, such as hydroxyapatite, are widely available. In summary, fluoride has a well-established role in reducing tooth decay, but concerns remain about cumulative exposure, systemic ingestion, possible developmental effects at higher exposure levels, and the potential impact on the oral microbiome. A cautious and personalized approach may therefore be appropriate, particularly for individuals seeking to improve their oral microbial balance. 3. Current oral care routine. The current routine consists of two different approaches. Morning routine. A non-fluoride toothpaste and mouthwash from Eluve Biotics, a UK company focused on oral microbiome support. Evening routine. A fluoride toothpaste and fluoride mouthwash before bed. This routine appears to represent a balanced approach. The morning routine is more microbiome supportive and avoids fluoride exposure, while the evening routine provides stronger anti-caries protection during the period when the mouth may be most vulnerable. 4. Rationale for evening fluoride use. The use of fluoride toothpaste before bed has a clear practical rationale. During sleep, saliva production decreases. Saliva plays an important role in oral health because it helps to buffer acids, support enamel remineralization, wash away food debris, regulate bacterial growth, and maintain a healthier oral environment. Because saliva flow is reduced overnight, the teeth may be more vulnerable to acid attack and demineralization during this period. For this reason, if fluoride is used, bedtime is arguably the most beneficial time to use it. 5. Oral microbiome considerations. The eubiotics approach is of interest because it appears to focus on supporting the oral microbiome rather than attempting to sterilize the mouth. This is consistent with a more modern understanding of oral health, where the aim is not to eliminate all bacteria but to encourage a stable and healthy microbial environment. This approach contrasts with older oral care strategies that relied heavily on antibacterial or antiseptic products. While such products may have a role in specific clinical situations, long-term routine use of strong antiseptic mouthwashes may risk disturbing beneficial bacteria as well as harmful ones. 6. Fluoride toothpaste versus fluoride mouthwash. It may be useful to distinguish between fluoride toothpaste and fluoride mouthwash. Fluoride toothpaste is primarily applied directly to the teeth and can help protect enamel by supporting remineralization and reducing acid-related damage. When used correctly and spat out, it provides a mainly topical effect. Fluoride mouthwash exposes the wider oral cavity more broadly. Depending on its formulation, it may also contain additional ingredients such as alcohol, chlorhexidine, cetylpyridinium chloride, or strong essential oils. These ingredients may have a greater potential to affect the wider oral microbiome, especially if used daily over a long period. For this reason, the fluoride mouthwash may be the part of the routine most worth reviewing, particularly if the aim is to improve oral microbial balance. 7. Possible refinement of the routine. A cautious and balanced refinement could be considered. The morning routine could remain focused on microbiome support, using the non-fluoride eubiotics toothpaste and mouthwash. The evening routine could continue to include fluoride toothpaste, particularly if there is any concern about tooth decay, enamel weakness, gum recession, dry mouth, or exposed root. However, the regular use of fluoride mouthwash at night could be reconsidered. In particular, it may be worth assessing whether it is necessary every evening, especially if it contains antibacterial or antiseptic ingredients. Another possible approach would be to use fluoride toothpaste at night but avoid rinsing immediately afterwards. This is because rinsing after brushing may wash away some of the fluoride left on the tooth surface, reducing its protective effect. 8. Alternative options. If dental risk is considered low, a monitored trial of a non-fluoride remineralizing toothpaste, such as one containing hydroxyapatite, could be considered. Hydroxyapatite is of interest because it supports enamel repair through a mineral-based mechanism rather than relying on fluoride. However, a complete move away from fluoride should ideally only be considered if the following conditions apply: no recent dental decay, good gum health, good saliva flow, low sugar and refined carbohydrate intake, no significant dry mouth, no exposed tooth roots, and regular dental monitoring. For individuals at higher risk of decay, fluoride toothpaste may remain beneficial. 9. Wider factors affecting the oral microbiome. Fluoride is only one part of the picture. Other factors may have an equal or greater effect on the oral microbiome, including frequency of sugar and refined carbohydrate intake, snacking between meals, dry mouth, mouth breathing during sleep, stress, sleep quality, hydration, interdental cleaning, and the use of strong antiseptic mouthwashes. Supporting the oral microbiome is therefore likely to require a broader approach than simply changing toothpaste. 10. Conclusion. The current routine appears to be a reasonable compromise between microbiome support and traditional enamel protection. Using a non-fluoride, microbiome-supportive product in the morning and fluoride toothpaste at night is a measured approach. It avoids excessive fluoride exposure while still maintaining protection during the period of greatest overnight vulnerability. The main area for review is the routine use of fluoride mouthwash, particularly if it contains strong antibacterial or antiseptic ingredients. A possible refinement would be to continue fluoride toothpaste before bed while reducing or removing the fluoride mouthwash, depending on dental risk and professional advice. Overall, the approach should be personalized. For someone with low decay risk and a desire to improve the oral microbiome, reducing unnecessary mouthwash use and supporting microbial balance may be sensible. For someone with higher decay risk, fluoride toothpaste may still provide valuable protection,